this is a typical picture of huge amounts of acne, and you can see that the skin is extremely oily. So a lot of hyperseborrhea, lot of acne which are inflamed, and they are florid, they are all over the face, and in general a hairy appearance. Although this woman does not have serious hirsutism as such, you can see that this is the photograph of the top of the scalp, and you can see here that at a young age there is a lot of recession of the frontal hairline. There's a lot of balding on the top of the skull, which is very typical of a male kind of pattern of androgen secretion. Now, insulin resistance has often been talked about, and yes, insulin resistance is part and parcel of polycystic ovarian syndrome, but sometimes you get syndromes which have very, very severe insulin resistance, and these are called Heran syndromes of or hyperandrogenism, insulin resistance, acanthosis nigricans syndrome. And if you see here, they often actually present as what is called pseudo-acromegaly. That means they look like acromegalic women, and this is a typical photograph. You can see here from the photograph itself that this lady has several things. You can see the florid acne that she demonstrates. You can see the coarseness of her features. It will be better appreciated in the next picture. You can see a lot of hair here, very thick confluent hair on the lower parts, and you can see here that all the skin creases here below the lips and on the neck, there is a lot of acanthosis nigricans. You can see here all these hair. You can see how thick the lips are, the bulbous nose, the protruding jaw. This person actually looks like having acromegaly, and this is not acromegaly. It is ruled out. This is called pseudoacromegaly, and this is a state of extreme insulin resistance. That means this girl has fasting insulin values which could run into hundreds or sometimes thousands, and her testosterone level, I don't remember, sir, if you remember this maybe, but her testosterone level came out to be 6 nanograms per ml or 600 nanograms per deciliter, and we had done a repeat testing couple of times, and it was proven there was no tumor, and it was all due to severe insulin resistance, because insulin will drive a lot of processes through the IGF-1. The insulin action is similar to insulin growth like factor 1, which is what is elevated in acromegaly as well. So all these actions are driven through the IGF-1 circuit. So some extreme forms of insulin resistance are also part and parcel of these things. When we talk about infertility, that's what really bothers most people. And yes, infertility is associated with polycystic ovarian syndrome. It's part and parcel of the anovulatory process. So there is chronic anovulation, there is poor follicular quality, there are poor pregnancy conversion rates even after ovulation. So it's not only the poor for ovulation, but the quality of ova is also sometimes dysfunctional. Dr. Yadnik will be speaking today in the oration. I don't know whether he will cover this topic, but now it is proven that children who are in the mother's womb, and if this mother has gestational diabetes, this girl who is in the womb now, in her later years, and her child are both at an increased risk of polycystic ovarian syndrome because of a variety of reasons. So the ova can be actually exposed to glycation in early pregnancy, and this glycation actually remains as a transgenerational influence and can actually cause problems in the future generation. So it's not just the girl herself, but her mother, her grandmother is also what influences the overall fertility and the overall clinical picture of polycystic ovarian syndrome. Pregnancy related problems of a girl who has had PCOS, they often are overweight, so the chances of developing gestational diabetes is clearly elevated, and this risk persists even after adjusting for weight. There is a risk of increased premature deliveries in these patients because there is a change in their hormone profile, and there is also small increased risk with preeclampsia, and this is very consistent with women who otherwise also have the insulin resistance syndrome or the metabolic syndrome without the polycystic ovarian features. So this is an overall feature of being obese, insulin resistant, being adipose in general, that they have increased risk of these particular problems. What about obesity in polycystic ovarian syndrome? Up to 50% patients are obese, and most of them have abdominal obesity. So most of the fat is actually concentrated near the waist, and you know that this fat has different connotations from fat on other parts of the body. And typically this obesity causes relative increase in androgen characterized by reduced SHBG. So it's all about binding proteins again and again. You may not find very high levels of testosterone in polycystic ovarian syndromes even if they are hirsute. Again, sometimes these reports are termed as trash because the girl has hair and you are saying the testosterone is normal. How can that be? It is because it's not just the total testosterone which is a problem. It is a problem of the sex hormone binding globulin, which when a person is insulin resistant tends to significantly go down. So total testosterone will be normal or very marginally elevated, but free testosterone or the free androgen indices will be slightly elevated because the free hormone content is higher. There is also increased production of testosterone, what is called the DHEA and androstenedione, and we'll come to these levels a little later when I talk of hirsutism. But please remember that all these so-called androgens, whether you call it DHEA or DHEAS or androstenedione or androstenediol or whatever you have it, they are finally all of them converted into testosterone. So if the testosterone is normal, it's very unlikely that a significant elevation will be found in any of these, unless you know you are talking of very specific blocks in the pathways in the adrenals of the glucocorticoid, mineralocorticoid and androgen synthesis. That means the various forms of the adrenal hyperplasia, but that we are not going to into right now. In a general patient, if the total testosterone is normal, you have significantly ruled out a major tumor or major blocks in the adrenal hormone synthesis pathway. There is, apart from androgen production, excess production of estrogen and estrone as well, because in polycystic ovarian syndromes, a lot of follicles are undergoing maturation together. They don't mature, that's a different thing, but they all start developing together, and therefore there is always a state of relative estrogen excess, which, as I said, is unmitigated by progesterone. So at any given point of time, you will find a lot of estrogen synthesis and estrone synthesis. So a lot of these girls might be brought to clinicians because their breast size is rapidly increasing, and part of that is because of hyperestrogenism. Yeah. Now, what about type 2 diabetes in polycystic ovarian syndrome? Again, 50% patients, as I said, are obese, and there is a 5 to 10-fold increased risk of developing type 2 diabetes. And this is something which many gynecologists also seem to forget, that what is really important about the PCOS is not just the ovulatory cause. Of course, that is important, but it is also the long-term risk of developing something immensely more sinister, and that is diabetes, hypertension, and cardiovascular disease. So 35% of patients will develop impaired glucose tolerance, and 10% will develop type 2 diabetes by the age of 40. That's a large number. And the risk applies to those even who are non-obese, although the risk is relatively less as compared to the obese people. So one of the primary things that is again and again harped to patients coming with PCOS is to change lifestyle, to try and get back to normal weight, so that at least this particular problem could be mitigated.